Um, Thank you, Dr. Chauhan. Even though I'm quite passionate about MRI, but I still agree there are some lesion in which I will send patient for cardiac CT, and the coronary artery disease is one of them. Even though with the advent of 3D whole heart, we get an absolute um, magnificent imaging for coronary artery disease, it's a hit and miss for us. So in case there is a dedicated question which is asked for coronary artery imaging, I'll still send patients for CT rather than MRI, unless there is a contraindication for patient not to go under cardiac CT or patient are a bit averse for any radiation. Good morning, everyone. Thanks for joining this session, and my sincere thanks to the PCSI organizing committee to give me this opportunity. Today, I will be talking about cardiac MRI in congenital heart disease. I have no disclosure. I will be talking about the background of congenital cardiac MRI, the usual referral process, the common indications, the standard CMR sequences, and the new frontiers. As we know that cardiac imaging has evolved in last 70 to 80 years, we started with cardiac catheterization in mid 1900s and then progressed to echocardiogram in 1970s. Since 2000, the cardiac MRI and cardiac CT has come to our advantage. All the modalities we use for assessing congenital heart disease has its own advantages and limitation. As you can see, the 2D echocardiogram has strong temporal and spatial resolution. However, cardiac MRI has a significant benefit when it comes to quantitative ventricular function, ventricular volumetrics, flow assessment, and 3D whole heart imaging. The usual advantages of cardiac MRI that is free of radiation. We can interrogate heart in any geometry as it's a 3D imaging. It's highly accurate and reproducible, and that's why it has become gold standard for assessment of volumes and flows. And again, it's particularly helpful in patients which require repeated imaging during their life course, such as repair tetralogy or coarctation of aorta. There are some limitations. The biggest one is the duration of study, and the patient has to lie in a narrow magnetic bore for the entire duration. Most of our imaging sequences are breath holding, and that's why if the patient is less than 7 years, we need a general anesthesia. It can be claustrophobic and noisy. However, kids manage it better than adults. There are significant metallic artifacts which can affect quality of imaging, and we need a significant human and technical resources to run this program. That's why we have to be very selective in choosing patient which require cardiac MRI. The biggest concern is MRI safety, and generally the patient and people who doesn't work in cardiac MRI or any MRI suite doesn't realize that magnet is always on. Even if there is no patient getting scanned, magnet never switch off. And once we do not follow the usual protocols for safety, disaster happens up to an extent of reported deaths. That's why it's really important to understand and follow the institutional safety policy. Regarding the CMR referrals, we generally prefer it to be done by primary pediatric cardiologists as they know this patient throughout their life. It should include demographics such as age, sex, weight, and height. It should have a complete anatomical diagnosis. Should include information regarding surgical and percutaneous procedure. It's always beneficial to have a result of most recent investigation, whether it's echocardiogram or catheterization. Any information about pacemaker or any metallic implant is highly valuable. However, for me, the biggest input I want from the referral is about what question they want to be answered, because depending on the question, whether it's a shunt analysis or a fibrosis or volume and function, we can tailor our protocol and sequences. So it's really helpful to be very specific and precise in the questions you want to ask. In terms of indication, so I would strongly recommend going through this paper, which was released by Society of Cardiac MRI USA in 2020, talks about clinical indications in cardiac MRI. And basically, the category one is the patient who are considered to be appropriate and should be considered as a first line. assessment. And these include evaluation of ventricular volume, mass, and function, measurement of pulmonary to systemic flow ratio, sinus venosus defect and anomalous pulmonary venous connection, systemic to pulmonary artery collaterals, similarly vascular ring, double outlet right ventricle, CCTG and truncus arteriosus, and last but not least, heterotexis syndrome and single ventricular heart disease. So all these now has been characterized as category 1. This is one of the standard cardiac MRI referral, which all the columns and information need to be filled up by the referring cardiologist. In terms of imaging sequences, I'll go through them one by one. To start with, we have initial pilots or multi-slice localizer. These are single-shot, quick, low-resolution imaging, mainly used for planning further sequences, and we acquire images in all 3 different planes. We do black blood imaging, which, as name suggests, in this sequence, the blood appears black and rest of the structures appears either gray or white. And it's really helpful to assess the vascular structures such as aorta or branch pulmonary arteries. We do a stack all the way from diaphragm up to the neck. And you can see that at different level, we have these imaging acquired. Similarly, we have white blood imaging, in which, again, as name suggests, the blood appears white and rest of the structure either gray or black. And again, we acquired stack from diaphragmatic surface up to the neck. And again, this is helpful to understand the vascular structure better. This is side-by-side comparison of black blood versus white blood imaging. And again, you can see that both sequences are helpful to understand the vascular structures. However, the main workforce of our imaging in MRI is 2D cine imaging. In technical terms, we call it as SSFP sequences. However, they are commonly known as bright blood or white blood cine imaging. We can acquire these moving cine images just like we do in echocardiogram in different views. We can acquire axial, coronal, and sagittal section, and using these, we can measure the chamber size and ventricular function. To acquire the stack of short axis stack, we first acquire 4-chamber imaging, as you can see on the left, and using multiple continuous slices, we have the stack or the series of short axis imaging. And then by doing contouring, whether it could be manual or using automated software, we can calculate the volumes, and thereby we can calculate the ejection fraction. 3D imaging is highly successful in sequential segment analysis of cardiac connection and great vessel, and to understand the complex spatial relationship of intracardiac structure. It is particularly helpful to plan complex cardiac surgeries or percutaneous interventions. We do by using the gadolinium as a contrast agent. We can see major aortic vessels, branch pulmonary arteries, and collateral vessels very clearly. As you can see, on the left is the raw image, and on the right, this is a video of volume rendered 3D reconstruction, again showing nicely all the vascular structures. However, there is a concern when we use gadolinium, and the biggest one is nephrogenic systemic fibrosis, particularly in patients with renal dysfunction. In my practice, if GFR is less than 30, I'd consider it to be high risk and only do the scan if the benefit outweighs the risk. Another emerging concern is accumulation of this contrast in brain. As you can see, this patient has 5 sequential MRIs and start showing accumulation by 4th or 5th scan. It's not a conspiracy theory. It has been proved by various literature. However, underlying mechanism is still unknown, and more importantly, we don't really
thus obtained provides much refined visualization of intracardiac anatomy.
Retain gadolinium. However, we are very mindful of that and try to minimize the use of gadolinium.
This virtual volume can then be edited for clinical decision
For that purpose only, we have come up with a new sequence, which is a non-contrast enhanced 3D imaging, also known as whole heart imaging. And using this sequence, we can actually acquire quite nice imaging of all the cardiac structure and vessel without using the contrast we can do all our measure using this particular sequence. Again, the benefit of we can do it without contrast. We can also do whole heart 3D cine images and acquire the entire block of volume in one attempt rather than having a different slices in different views. To assess the shunt or assess the collateral volumes, we can measure flows across different vessels. This chart just shows different calculation we do based on the question asked. Just like echo, we can do strain imaging using cardiac MRI. Myocardial stress perfusion is particularly helpful if we are considering any acquired or congenital coronary artery disease. A big advantage of doing cardiac MRI is to find out myocardial fibrosis. As you can see, the image on the left shows patient with ARVC showing fibrosis in the free wall, and on the right is a patient who has cardiac fibroma, both showing significant enhancement. MRI is particularly helpful for tumor characterization, and looking at different sequences, we can identify what kind of tumor it is. For example, rhabdomyoma versus myxoma versus fibroma. This is a typical planning sequence we used at our center. There are new development happening in cardiac MRI, such as 4D flow, fetal cardiac MRI, MRI-guided percutaneous intervention, and as with any other field, the artificial intelligence is getting increasingly important. Finally, it's a team effort, and I'm really grateful for my entire team for making this program a success. And that's pretty much is my presentation. I'm happy to take any questions now. Thank you.